What's up, guys? I'm Dr. Qasim Butt. We're gonna wait a few seconds just to get some more people on. Just relax, and we'll get some more people on. All right. We're about to start, guys. Give us a few minutes, okay? A few seconds. Oh, we got some people. We got some people. Awesome. Hey, everyone out there right now, first off, like and share this video if you can. Help us out a little bit. Also, in the comment section, tell me who you are, where you're from, and your relationship to kidney care. I'd like to know how you're related to kidney care. You're a doctor, nurse, entrepreneur, in med device, whatever it is. Let us know in the comment section. I'd love to give you a shout out. All right, guys. Looks like we got some people on. I'm actually just going to go ahead and start. All right. All right, guys. What's up, San Antonio and world? I'm Dr. Qasim Butt, and I'm a kidney doctor. I am a nephrologist, a board-certified nephrologist and interventional nephrologist. I've been doing that for about 11 years or so. Left my practice in November of 2021 to pursue more entrepreneurial ventures. I guess you could say I'm a part of the whole Great Resignation, if you would. I left. I'm doing nephrology part-time now, advisor to several companies in the kidney care space, one of which is Icona Health, which is a kidney disease education, super cool company. Right now, I'm actively involved, though, in Allele Medical. Allele Medical is a company that's designed a remote patient monitoring patch specifically designed for kidney care and dialysis patient. It goes on your fistula. And I'm going to put their information in the comment section so you can check it out. If you want to see what innovation in kidney care is like, please check out the Allele Smart Patch. We're going to go ahead and start today. I'm really excited about this. This is something, I wanted to do for a while, actually. And I was fortunate enough to get these guys on. So let's just start where it started. Okay. It started with this picture. So there's a point in life where you reach where you realize that things ain't going to be the same anymore, right? That could be professionally, that can be personally, whatever it is. It started when I saw this picture, and this picture is actually from the RPA meeting, the Renal Physician Association meeting in I forgot where it was, in Dallas. It was in Dallas, and this picture is actually of the new CEOs of kidney care startups that are in value-based medicine. Okay, so I saw this and I was like, this is not. We're in a different time now. And I posted this post, Changing of the Guard in Kidney Care. And I got so many responses to it, so many engagements, people reaching out, talking, discussion. And then I was like, I posed the question, hey, who wants to talk about this? And I got a ton of response. And some of these guys decided, hey, come on, we wanted to come on with me. So that's how we got here. Now, let me give you some of the basics of the U.S. healthcare system, okay? The U.S. healthcare system is a fee-for-service system, fee-for-service, okay? What that means is, when you see a patient in clinic, you bill, you get paid. When you see a patient in the hospital, you get paid. You do a surgery, you get paid. The more times you see a patient in clinic, you get paid. The more times you see them in the hospital, you get paid. So this creates an incentive structure to where it incentivizes you to do more for a patient, but it doesn't incentivize you to do better for the patient, right? So again, people keep seeing them, but again, not necessarily getting better results. And our Medicare system, our traditional Medicare system, is a fee-for-service system. Okay, Medicare, of course, is the insurance that we have for the elderly, right? Part A, Part B, and Part C. Part A, you bill for hospital costs in the fee-for-service way. Part B, you bill for doctor's appointments and outpatient procedures in the fee-for-service way. And Part D, you bill for home medications in the fee-for-service way. Right now, with Medicare in particular, Medicare has a very interesting relationship with kidney care. It's not like no other. Okay, Medicare typically is an age qualifying insurance. That's how we understand it, right? You turn 65 and you qualify for Medicare. Well, there is an exception to that rule, and that rule is the diagnosis of end-stage kidney disease. In 1972, President Richard Nixon signed into law that anyone who's on dialysis is covered by Medicare. So you have 30 and 40-year-olds that have Medicare because they're on dialysis. But in 1972, we only had 10,000 people on dialysis. As of right now, we have over 500,000. And in 2016, Medicare spent over $114 billion to cover people with kidney disease. That's $1 in every $5 Medicare spent was on people with kidney disease. And the funny thing is, no one knows about this disease. So what's the result of the current fee-for-service model? For a current result is 90% of dialysis patients are done in an in-center setting, not at home in the comfort of their homes, but in an in-center setting. Okay. More hospitalizations, we have worse outcomes, we have late referrals to kidney doctors, right, to the nephrologists. They get referred to us, guys, when the kidney function is close to end stage, when it's less than 30%. Quite honestly, at that stage, we really can't do much for the patient. We have this phenomenon called crashing into dialysis. And what that means is a patient may never see a doctor or may see him occasionally. All of a sudden starts feeling bad or weak or whatever, shows up to an ER, and all of a sudden the ER doctor comes up to him and goes, "Hey man, your kidneys aren't working anymore, and you're going to need dialysis for the rest of your life." And that's the kidney care experience for so many of our patients on dialysis when they start dialysis. Okay. You also have the underutilization of kidney transplants. We have tons of people waiting for kidney transplants, but we also have a lot of people not getting referred for kidney transplants. And kidney transplants actually can save money, but also have better lives and outcomes. Then comes in the executive order. The executive order was signed into law by President Trump in July of 2019. It's been carried forward by Biden. So luckily, this is that has bipartisan support. Brought into law by Secretary of Health and Human Services, Alex Azar, whose father had kidney disease. And his father was on, I think, PD, hemodialysis, and eventually got a kidney transplant. So he's seen the entire spectrum of kidney disease in America. He wanted to come up with a bold new plan, a plan that pays for a system that pays for kidney health rather than kidney sickness. And how do you get there? You got to set some goals, right? You set the three goals. The three goals of the executive order were by 2025, 80% of new ESKD starts are on either home dialysis or preemptive transplant. Let me explain that again. In 2025, if you're diagnosed with end-stage kidney disease, they want you to do dialysis at home or get a kidney transplant before you ever need dialysis, okay? The other goal was by 2030, reduce the incidence of end-stage kidney disease by 25%, and by 2030, double the number of kidneys available for transplant. Now, to be honest, these are kind of Trump numbers, but at the same time, I think you have to set lofty goals to achieve something good, right? So what is value-based care, right? What we just talked about with the three goals is to actually create value, not just create revenue, right? So what is value-based care? That means you're not driven by just more revenue, more visits or procedures. Rather, you judge a physician in the practice by their outcomes, by how much they save costs, better mortality, less hospitalizations. And CMS in particular came out with that executive order, came out with new kidney care models, the ETC, the KCF, and the CKCC, these models. Now, we're going to go talk about them to some degree in a few minutes. But if you want to know in depth, I did a 20-minute video on it. If you want to know about those models, it's just a 20-minute video. It's on my website, Your Kidneys, Your Health. You can check it out. If you're a physician, you can get CME and for that video, and you can get CME for this webinar as well. So how do you change the value base? Most physician practices don't know how to change. I think a lot of insurance companies don't know how to change, and even Medicare sometimes doesn't know how to change. So they've come up with some new kidney care startups, and those are the ones I'm going to talk about. One of the biggest players is probably Somatis. Okay, Somatis, the co-founder and CEO is Ikenna Okezi. He's previous with DaVita. What you're going to notice is a lot of these companies, they're headed by former DaVita and Fresenius guys. I call it DaVita University, right? They all graduate and they start their own startups. They're headquartered in Washington, D.C., founded in 2016. I'm going to go over the investors. Now, they have a lot of investors. Each one of these companies have a lot of investors, but some of the investors here are Optum and Blue Cross and Blue Shield in this company. And the investors in a company really tell you, where the company is going or why they invested in it, right? So it tells you a lot about a company, who their investors are. Now, their amount raised, they have raised about $465 million. In the recent Series E financing round, they raised about $325 million. I bring up that number not to tell you that this guy is cool. I bring up that number to tell you that this is the attention that kidney care is getting right now. This is the amount of capital being pushed into kidney care. It could be very good for our patients if it's done right. The value of the company is about $2.5 billion. Strive Health, another one, is co-founder and CEO is Chris Ryapel, prior to Vita guy, headquartered in Denver, Colorado, founded in 2018. One of the lead investors in this company is Capital G. Capital G is the venture arm of Alphabet. Alphabet is the parent company of Google. What you're noticing is technology companies are coming into healthcare and they're coming into kidney care. The amount raised for this company is about $220 million, pretty impressive as well. Cricket Health. We have CEO Robert Sapucha, previous Fresenius guy. I actually got a chance to meet him. Really nice guy. Headquartered in Boston, Massachusetts. Founded in 2015. Investors in this company are Cigna and Blue Shield of California. Amount raised about $111 million. And recently in the news, they've actually partnered with Interwell and Fresenius Health Partners as well. Monogram Health. Founder and CEO is Mike Ukrin, headquartered in Nashville, Tennessee. Founded in 2019. The investors in this are Humana, but also tongue-tied, Frist Cressy Ventures. Frist Cressy Ventures was co-founded by Senator Bill Frist. He's a senator a former senator out of Tennessee. Really innovative guy. He was a former, I believe he was a cardiothoracic surgeon. He's created a venture fund like this to invest in new startups, not just in kidney care, but in healthcare. Amount raised in this company is about $172 million. Evergreen Nephrology. Evergreen Nephrology is founded by founder and executive chairman is Adam Bowler. Adam Bowler is a really interesting guy to me. He's the director of CMMI, which is the innovation arm of Medicare. He was involved in the kidney care models, the formation of them. He was the CEO of Landmark Health as well. Very innovative guy. Headquartered in Nashville, Tennessee. Founded recently. Investors in this company are Rubicon founders, which Adam is the CEO, and the amount raised is unknown. Lastly, we have Panoramic Health. Panoramic Health is a co-founder and CEO is Rajiv Patel, and the co-founder is Gurdev Singh. And guess what? Both of these guys are nephrologists. So go Team Nephrology. They're the only founders amongst these startups. Founded in 2017, headquartered in Phoenix, Arizona. Investor is a private equity company, and the amount raised is unknown on this company. But guess what? The large dialysis companies see the tea leaves, right? They see the changes happening in the market. They can sense what's happening. They've created their own value-based medicine divisions or companies to handle this as well. So this is the new wave of innovation that's coming into healthcare, the management of these patients. Now, to begin, luckily I've collected a ragtag all-star group of value-based medicine guys. I'm excited to have them here. I'm just going to start the introductions here. First off, we have one of the most innovative nephrologists I've ever got a chance to meet. He's active in artificial intelligence, machine learning in kidney care. He's one of those guys that has way too many initials behind his name, and some of them I think he just made up. So let's bring to the table Mufaddal, Dr. Mufaddal Kheda from ChenMed. How's it going, Mufaddal?
Hey, Qasim, how are you? Hey, thank you for the introduction.
Tell us about yourself, man. You work at ChenMed. Just tell us about yourself.
Yeah. So once again, I'm Mufaddal Kheda. I'm a national director of the kidney care program, kidney care at ChenMed. And those of who in your audience may not know ChenMed, it is a premier primary care provider in America. We serve over 100,000 patients in 12 different states. We have over 90 centers, outpatient centers, where we employ 400 primary care physicians and deliver care to the patients. And the type of care that we deliver is, you can classify that as concierge medicine quality care, where we have each physician has low panel size. Our patients have access to our physicians 24/7. We provide holistic, high-touch care. We see our patient every month. So it's a beautiful setup and a wonderful care that ChenMed provides, and I get to be part of it. So, Qasim, and to add to that, what is a nephrologist doing over there now?
Yeah, what are you doing?
So I am building ChenMed Kidney Care Program. This is you introduced some companies outside who are providing kidney disease management. We are building our own kidney disease management system in-house from ground up. We can talk about all the technologies that we are using to build it, but what we are mainly using at the core of it is our primary care physician. Healthcare is local. The PCPs are the best who knows these patients. They see them every month. And so we're designing kidney care and delivering kidney care through our PCP's lens, and then obviously partnering with the nephrologist in the community. And we are addressing crash into dialysis, catheter rates, all those kind of fancy things that nephrologists.
Yeah, that's crazy to me, man. That's great. The PCP is actually getting involved in there, and that's interesting. And you wonder where that goes, eventually. And so PCP is going into kidney care, and you wonder if a lot of disease processes can be stopped by better primary care management. You see what I'm saying? Not just getting him to the end stage. So
you and me, we do this all the time, right? When you ask patients or you ask, how do we slow the progression of kidney disease? And you have a CKD stage 3, what would you do? You would do things like, oh, I want to control their diabetes better, hypertension better, lifestyle changes, address the SDOH and nutrition. These are wheelhouse for primary care doctor. That's what they do.
We're going to go into it. I'm going to bring on the next guest. Okay. The next guest. This man, he put the value in value-based care. Okay. He's been doing value-based care and kidney care before it was cool. All right. I've got a chance to talk to him, and he just has extensive knowledge of value-based medicine. From Balboa Nephrology, we have Dr. Bijal Patel. What's going on, Bijal?
Hey, thanks, Qasim, for having me on. I appreciate really being here. But yeah, let me tell you a little bit about what we've been a part of. I was a primary care physician before I became a nephrologist. And really, I always found that the patient interaction and the patient relationship was the most important. And I just kind of wanted to go deeper with let's say I thought initially less patients going into nephrology, but that's not necessarily the case. I joined Balboa Nephrology in 2007. And as the new guy, I kind of started off with home dialysis. And at that time, we had 12 patients in home dialysis. And currently, we have over 650 patients on home dialysis.
Wow. That's more patients than most nephrologists have in their whole practice. You realize that?
Yeah, right? Maybe so. Well, I mean, we have a group of about 56 or 57 nephrologists. We also have our 2 transplant surgeons. So we run our own transplant program through Sharp Healthcare. We have research. We have an access center. And so in value-based care, we really started even before I started with Balboa Nephrology, which was in 2006 to 2010. We did a demonstration project, the initial demonstration project in nephrology with CMS. And
you're talking about the ESCOs and the ACOs?
No. We did a demonstration project.
Hold your roll. We're gonna get into it.
Okay, so
I got one more guy coming. Okay. All right. Are you ready?
Sure.
So we got I saved the best for last. Okay. I saved the best for last. I'm bringing in the referee from the fight. I'm bringing in the guy that managed the Clash of the Titans, the guy that managed all those CEO egos on that RPA stage. The man he manhandled them. From Fresenius Health Partners, we have David Arrieta. David, what's going on, man?
Hey, how are you, Qasim? Thank you for having me tonight, and thank you for all the audience members who have joined us as well. My name is David Arrieta. I currently reside in Franklin, Tennessee. So hello to all the Tennesseans on the call. But tonight, speaking to you from Florham Park, New Jersey, where I'm at for business. Overall, I'm the strategic advisor for Fresenius Health Partners, helping them engage physician practices. What we've realized, Qasim and Bijal and Mufaddal, is that as you incorporate value-based care tenets into a nephrology practice, the entire practice has to change in order to support value-based care. It's not as easy as just saying, today we're going to start doing value-based care. And the difficulty, or one of the challenges, is that you have a certain percentage under value-based care and you have a certain percentage under fee-for-service. And how do you incorporate that at the practice level? So in my position, I get to help the 20 kidney contracting entities that Fresenius Health Partners is engaged with, 73 practices around the country, in helping them look at their operations and how do we make those more efficient to both take care of patients under value-based care as well for fee-for-service and provide the patient outcomes that we all expect from.
And that's what we just talked about, David. Like that, as a physician, when you're seeing a patient, I don't know what insurance they have or what company they're with or whatever. So how do you balance both the fee-for-service and the value-based? But let's just get into it, guys. Let's just get into it. So I'm going to start off with the question, and anyone can take it. What is value-based care?
Well, I'd take a stab at it because that's what we do day in and day out. So you can define value-based care, and it's got some of the bad rep about not able to define it correctly. So I tell you, you can define a value-based care just by economics. And economic definition would be anything that's not fee-for-service. The things that you described, Qasim. If you're not delivering care based on encounter-based, RVU-based, those kind of things, then anything that's not fee-for-based is quote-unquote called value-based care. And how other way to understand what is value-based care? If you know Medicare Advantage, that is value-based care. So if you just think, what is Medicare?
Let's go into that real quick. Let's just go into that. Like, what is the difference between Medicare Advantage and fee-for-service, and how is Medicare Advantage value-based care? But go for it, and anybody can take it, by the way. Go for it.
Yeah. So,
go ahead, Bijal.
Yeah. So, I mean, the way I think, just to start, like the way I think about value-based care is really gives us a chance to have the responsibility for the outcomes. That's really the whole purpose of it. We can talk about cost. We know cost is always going to be high, but really for all the money that we're spending, are we getting the best quality, and is quality determined by the outcomes? And so when we think about Medicare Advantage, it's really a capitated payment. And so now when you have a capitated payment, which is basically a fixed payment per patient per month.
And again, not the fee for service. You get it straight per month or per quarter. I guess it could vary, right?
Yeah, it could vary, but it's a fixed point of time. But let's say most people say PM per member per month. And what I would say is that what it does is it gives you a pool of money for then smart people like nephrologists to go ahead and innovate and give the best care that they can, not just fee for service. Right now, if you're talking about fee for service, we see a patient, we tell them to come back in 3 months, we see them again. Many practices are not going to invest in all the services that Mufaddal was talking about, whether it's having a dietitian or a wound care nurse. Nobody's going to invest in those in those personnel when you don't have the money to do that. And so to me, capitated payments allow us a chance to innovate and give us the freedom to do what we think is best for patients. That's what I love about it.
And when I was with my practice, the idea of a consistent revenue stream is really appealing to any business, right? As opposed to having cash flow going up and down, right? Or waiting for revenues to come in, right? Would you agree with that?
100%.
100%, right? Yeah.
If you know what your cash flow is, then you can make proper investments in the future. And that's what our patients need. They don't just need today, okay, I'm going to get $50 for this visit, so I'll do what I can. They need to know, practices and businesses need to know they're going to have a margin to serve their mission.
And I think that's a hard part for a lot of doctors to get at. They may make a certain amount when they see a patient in the hospital, when they see the patient in clinic, but then they're saying, oh, you can get this capitated payment that's actually smaller. Do you see what I'm saying? And I think that's a hard sell for a lot of people to grasp that, hey, that's actually better to get that smaller capitated payment over time than maybe a bigger payment every once in a while, right? So.
Yeah, I mean, I don't want to take over some of this stuff.
Yeah. So let's see here. So let's go over ESROs. Okay, so Bijal and anybody else, anyone knows anything about the ESROs, and can anyone explain what it is?
Sure. So, the ESROs were the original demonstration project, not really the original. They were the second wave of the demonstration project through Medicare to demonstrate that we were able to, as nephrologists, take better care of patients by controlling the entire continuum of care for those patients. It wasn't as successful as Medicare expected it to be. There was large practices such as Balboa and San Diego that did very well under that model. But overall, the program from the latest results and the reports that have come out after the program sunsetted was that, yes, it saved a little bit of money, but it wasn't a large transition that Medicare was expecting. So they relaunched, in my opinion, 2.0, moving into what we now have, the CKCCs, in order to correct some of the problems that existed under the ESCO, give a larger pool of payments towards the nephrologist. And as Bij was just talking about with the capitated payments, the assumption from CMMI and Medicare is that you use some of that extra money that you're getting for those patients in order to do more care coordination, build a larger infrastructure around those patients. So for me, ESCO was the first iteration of what became the CKCC. Mildly successful. It didn't save the substantial amount of money. And now we have the CKCC, lots more control under the nephrologist as opposed to the LDO. So another effort at giving us an opportunity to do it the right way and see if we as nephrologists, tonight I'm going to count myself as a nephrologist just because I'm on we in the nephrology community can we do a better job of coordinating that care.
Well, that's what I want to say. Like the ESCO initially was more dialysis provider centered, right? They ran it, right? Whereas these new models that are coming out, and the models are the ETC, the CKCC, and the KCF, or more physician practice focused. Is that a safe assumption?
Absolutely.
Yeah, that's correct. I think anytime, the whole value-based care it's a team sport. All right. To deliver value-based care, you need the nurses, you need the IDT teams, the dietitian, the wound care, the primary care. And when we're engaged with a lot of clinicians in delivering care to the patient locally, the best agent to do or coordinate all that is the physician in the center. And I think one of the downside of the ESCO 1.0 was the center was thought to be an organization, not the physician. And physician was thought to be just one of the agents, which did not work out well. We see it in the primary care models. So when primary care has done very well with any kind of value-based measures, or ChenMed is a value-based company, value-based care company, and I think we do very well, just because we put our physicians at the center of care, and everybody, all the delivery services and teams rotate around that physicians need, which he or she would assume what's right for the patient. So.
And let's just differentiate so people know. So some of the new models that came out, the kidney care models that were in the Trump executive order, are the ETC, which is the mandatory one, right? That goes to, I would think, 30% of all the physician practices in the country. So they have certain metrics that these physicians have to meet. Then you have the two voluntary ones, right? And that's when we're talking about the KCF and the CKCC. Both have similar kind of metrics, but the KCF is actually the practice goes by themselves, correct?
They can choose to go in by themselves. Qasim, it doesn't necessarily have to be that way.
Yeah, well, I'm saying if they went by themselves, that's the KCF, right? If they go in with the CKCC, that they're going in as an entity, correct?
Correct,
right? And that's what Fresenius Health Partners is helping facilitate, and a lot of these new startups are helping facilitate, is the CKCC model, right? Where you create an entity and that manages the patient, correct?
Absolutely correct.
Okay. Can I ask you something? Well, we don't want to get too much into these models too much, but we had the HMOs, I think in the 90s, right? And they introduced the capitated payments and all that stuff. Why do you think that failed and this will work? Do you guys have?
Yeah. So what I would say, I mean, we're in San Diego, and in Southern California, it's a highly managed care or
not failed. Excuse me, not failed. I didn't fail. Yeah. Sorry, but go ahead.
Yeah, I mean, I think that the thing is that we have to be careful to put everybody in the same bucket. I mean, the ESCO, we can say that overall, it didn't really make so much savings, but in San Diego, we actually did quite well in the ESCO. I think just the same thing with managed care. Everybody has to be speaking the same language. You can't do managed care trying to do value-based care while a majority of the doctors and healthcare systems are trying to capture more fee-for-service. It just doesn't work that way. The only way to get real value-based care, or hopefully one day, again, it will be called care, is to get everyone on the same page to say, here's the whole umbrella of what we're trying to do. We're trying to achieve these outcomes. And the only way we can do that is really all of us working together. Again, even if you're carving out some value-based care, but you're really not taking on the whole global accountability of the care, very difficult, I think, to make major strides in achieving 80% home therapies and large amounts of transplant and preemptive. It's going to take everyone to be able to be on the same page. And I think the tough part about managed care or HMOs is that not everyone is always on the exact same page.
It's not integrated. It's not integrated.
Yeah, it's not. I mean, it just depends. And so if you can find healthcare systems that have everybody playing in the same, they're probably going to be better off than places that are kind of piecemealing it together.
Okay. Let's go into the next topic at hand. What changes does a practice have to make it more value-based? What does it have to do? Anybody?
For us, I would say that, look, everybody's used to fee-for-service. That's how we've been raised throughout our training and so forth. So when we're talking about we're in value-based care today, we've been beating the same drum for 15 years. Yeah. And we still have ways to go. And so it's very difficult to take, while we're paying doctors, we don't have a common pot necessarily in bowel nephrology. We say, if you work harder, meaning you see more patients, you get paid more. So to just say, how do we change that all of a sudden? It's not an easy task, but I think that beating the same drum of what our purpose is, what our opportunities are to achieve better outcomes, it has to be collecting data, giving back data to the individual physicians. We in our group are actually going through a practice redesign where we're not even just going to look at data for just the physicians, but we're going to do it by pods so that we can focus on more of a team effort.
Yeah.
Because we believe that, some of us are going to be taking vacation, hopefully, and when you're not there, your other members of your group can be able to kind of fight for the same outcome. So I think that's the first biggest thing, that are we all aligned on the same purpose and mission? That's
I'm thinking it from the perspective of the smaller practices, right? You come from a big practice. ChenMed is a big practice. I think David, you've worked practices that are pretty big, but how does a small guy navigate all this water? You know what I'm saying? How did they go about it? Do they have to pair up with other nephrologists to do this, or how would they go about it?
I think that, go ahead, David.
David would be great to answer
this. I was going to say, if you're looking at the creation of the KCE and looking at the CKCCs, the smaller practices, because you're smaller and you have a smaller nucleus of patients, it does make sense a lot of times to aggregate with other practices and create a bigger risk pool for that particular KCE, so that you don't put a lot of the risk on a small number of patients, where if you have one or two bad outliers, you can really have some dramatic impacts on overall your total cost of care. So it is important for the smaller practices to look for partners. It doesn't have to be someone like Fresenius Health Partners, but to look for other practices within their areas. And sometimes actually smaller practices are at an advantage from the perspective of that they can go speak to the cardiologist that's down the hallway. They can go speak to the health system a little bit easier sometimes than the bigger practices, because they have closer relationships in those smaller communities and smaller practices. And so I've worked now with 3 or 4 small practices that are involved in the KCE, and the ability for me to speak directly to the administrator, directly to the doctor, and be able to the next day see an impact on how they're taking care of patients. Tremendous hats off to the smaller practices from that perspective. But I do see that they need to, for the most part, aggregate with somebody, bring more lives into the risk pool in order to minimize their risk.
So I'm gonna. That was an excellent point. I'm gonna pose a biased perspective. I'm an interventional nephrologist, so I'm gonna ask you something. To do proper value-based care in kidney care, do you need to set up a vascular center, an OBL, AS, or ASC? Do you think that you need one? Go for it.
I think I'm gonna, go as many services and stakeholders in the total picture and total spectrum of care. One of the things, let me track back and say, in the value-based care, what you're doing is you're taking care of the journey of the patient through time zones, right? It's not episodic. Somebody got sick or somebody needs something, you deliver care. It's like journey and the transitioning from stages of kidney disease. How do you help the patient transition from CKD to ESRD? Within ESRD, if they got an access problem, who's going to handle their access episode issue, or when they need a new access? So you need probably as many services you can align with, including access center, in that journey for the patient. Value-based care to me is just about that. It's if you're somebody who's designing a service for value-based care, think journey. That your patient with chronic disease is going to go through this 5-year journey of late stage and ESRD. How am I going to design my care? I can take the patient from A to Z in different stages of patient's life.
I really like that explanation, explaining the patient journey and that experience from CKD progression to dialysis, and even vein mapping and all that kind of cool stuff. But I'm just curious as to I think you'd have to have one, or at least really coordinated with a surgeon or somebody else to have that implemented, right? Because I just don't see how, I talked about crashing onto dialysis, right? But how do you implement what they call optimal starts, right? The optimal start, get the vein mapping, get the access ready, initiate outpatient. I think you'd have to have a center. Would you guys agree with that? Or
I think the center helps a lot because it's a place for innovation. While we can have innovative payment models, you have to have places for innovation to happen. Now, I think if I was a small group of 2 in a smaller area, you're going to say, well, there's no way we can do it. And if there's no close other way to aggregate, because I totally agree with David, you kind of have to act like a bigger group to pool more patients, but pool services. But then I would look at, if that's not possible, I think I would look at talking to the local hospital, what their outpatient center? Is there an interventional radiologist that's, willing to do, is there a surgeon to kind of book outpatient block time for access work so that they're not getting hospitalized or not getting clotting and then have to be hospitalized? I think it can be done in different ways, depending on where you are in with healthcare and how big it is. But for sure, if you have ability to kind of be part of an access center, I think it helps a lot.
Yeah, no, I totally agree. I just think it's hard for a smaller practice to have that available. And what's interesting is with these models, the capitated payment that we're talking about is not including vascular access work. Vascular access work is still be billed fee for service, correct? They'll still be billed fee for service, like the interventions, the fistulograms, the surgeries, all that kind of stuff, right? So, but eventually it does affect the total care of cost, right?
I think it depends on the model. I mean, if we're in a global model, so anything.
Yeah, but the capitate. Oh, I guess it would. Yeah. Okay. So it does affect the global the risk that you're in, right?
Yep. It depends on the model you're in, but let's just say for balboa nephrology and a few of the other areas around the country that we're in a global model, we're at risk for all of it.
Okay, great. Let's just talk about the kidney care startups that I brought about. How are they implementing VBC, and how do you see people partnering with them? And you guys have great experience with this, so go for it. And by the way, anyone else has questions? We're going to start fielding the questions in a few minutes. So after these questions, go for it. Oh, I just said, how are they implementing value-based medicine, and how are you partnering with them and all that kind of stuff with these new kidney care startups?
Sure. And I think I'll take a generalized stab, and then Bij and Mufaddal can maybe talk more to specifics. With a practice that I helped run in Nashville, I had access to all of the agreements for all of the companies that you mentioned, as far as working with them and considering them as partners. And really what they all bring to the table is the infrastructure that a physician needs to feel a little more comfortable with going into an at-risk model. I think one of the things that we haven't talked about is the degree of change that a nephrologist has to go through. The nephrologist on this call and on this event, when you prescribe a medication for one of your patients, with clinical clarity exactly what's going to happen when that patient takes the medication, assuming they take the medication. Exactly what's going to happen with their blood pressure should they take the medication. The problem or the challenge is that all of these new models, we have no clarity on what's going to happen 2 or 3 years from now. We have to jump in. We have to create infrastructure, care coordinated teams around that. That costs money. It costs effort. And you as a nephrologist have been able to subsist in the fee-for-service world for a long time. And to Bij's point from earlier, we've done everything the same way for a long time. And now we're asking you to make multi-million-dollar investments into something that will not theoretically pay off until 2 or 3 years from now if we do everything right. And so I think the nephrologists, we underestimate the amount of change that nephrologists are going through. And the VBC companies that are out there are coming to partner with the nephrologists and saying, we can help provide that infrastructure. We can help shoulder some of the risks so that you don't feel as isolated as a nephrologist, but you are going to, in exchange for that, have to make changes to how you see patients. You can no longer operate in the nephrology silo, and you're going to have to capture other specialties along with that. So I think every single one of those companies brings that to the table. I think everybody who's considering an association with the VBC company needs to choose which one they feel the most comfortable with, which financial model they feel the most comfortable with, and also just know that we don't know exactly how all this is going to end up. And no matter the interventions that we make, we think they're the best ones, but they may not turn out to be the best ones, and we have to be willing to adjust along the way.
No, so that's a good point.
David, add to your comment there. Yes, they bring, and to at ChenMed, when we decided to build versus buy question for our program, and we decided to build our program, we went and talked to these companies where we valued, what are the services they're bringing. And to me, these services are what we call wraparound services in our terms. Okay, and they're very important services: education about kidney disease, education about dialysis, transitioning patient onto dialysis smoothly. All these services are great. That's what we need. Why do we need this company, and why haven't we done it? It's because our failure of our system to incentivize and pay the nephrologist for these services. No nephrology office invests time, adequately in educating about dialysis and preparing for dialysis as much as we need to. Part of it, there's no incentive in fee-for-service world. And we have these companies come around saying, hey, we're going to do it for you. And guess what? We're going to ask the payers to pay for this because, they will, because the outcomes will be better, hospitalizations will go down. And that's how they have come to the market. It's just beautiful to see that now nephrologists are coming in the norm where we can do these models ourselves. We get global payment system like Bijal mentioned, and now we can invest into these services outside the traditional fee-for-service system where even though we don't get paid, but we get a capitated payment and we can invest in it.
Yeah. So, so like, I think like some of the kidney care startups that we talked about, the value-based medicine, some of them are more payer focused and some of them more nephrologist focused, right? Would you guys agree with that?
Yeah. Correct. And I think we've seen a change in that, Qasim, from the earlier value-based care companies went after the payers first, and then came to the nephrologist and said, hey, nephrologist, we have a contract with patients that are aligned with you, and we'd like to pay you X number of dollars per member per month. I think the nephrology community did a very good job at pushing back at those initial setups where the nephrologist wanted to be involved in the initial setup of the entire contract and moving through that in order to value the nephrologist services more than they were being valued initially. So I think there's been a change there. It was like 1.0 and the first group of value-based care companies went after the payers. Now you see a much larger focus on the nephrologist and using the relationship with the nephrologist to approach the payer overall.
Let's start fielding some questions, guys. I got one right here. Let's see here. For the panelists, I guess LinkedIn user, generic name. For the panel, how do you folks feel about the value that pure tech players in the kidney care space, Cricket, Strive, deliver compared to integrated clinical models like ChenMed? Oh, this is a shout out to ChenMed here. Okay, go for it. Go for it.
Well, proud to be, with that said, we have, as much as ChenMed, we brag a lot.
One second, move it up. Like, so the Crickets and Strives are more virtual based. Am I right to say that? Is it more virtual platforms? Is that right?
I think the initial implementation of the both, I believe, if I can, a lot of is technology based, predictive models, and assist the providers with data so they can do meaningful interventions. So they were supporting the providers with data, models, and result, and so the providers could act upon. At ChenMed, we actually do all that. We actually talk about our technology stack, how it's helping our PCPs and all. But what we really also brag about is the person who's going to deliver the care to the end. So when they say integrated clinical model, you cannot do good clinical integrated model or delivery of care without technology behind it. If an ESRD patient is always a quote unquote high risk patient, right? I mean, we all know dialysis patient, but within the dialysis patient, we use predictive models to create it into 3 different strata of patients, and then we intervene differently depending on their risk factor within the dialysis patient.
So I actually think the whole predictive models thing is going to be a game changer. Like, being able to detect who can get CKD or who's at risk for fast regression and all that kind of stuff, I think is, super cool. I think that's going to be the wave of the future. But to the point, like, even though the predictive models are kind of cool, I think the sheer fact of having an integrated health system is so important, right? Like, I don't think most people understand that as a nephrologist in most settings, I have no idea what the cardiologist did. I had no idea what the PCP did. So there's lack of communication there. And that's something we don't
repeating this again, Qasim. Again, I'll say value-based care, innovation in kidney disease, which is value-based care, is a team sport. I mean, you got to need people, you got to need personnel of different trades and skills to play together to deliver care.
Yeah, absolutely. Absolutely. Let's see here. We got Rajiv Vijay. Let's see here. This kind of goes to what we said before. Thanks, Rajiv. How can small, medium practices even be successful in KCF with the overhaul and infrastructure that's needed? And in CKCC, is a nephrologist on center seat or startups with big pockets? That's a good question. So the KCF, he's right. There's no way a small practice can take on the KCF, go into a at-risk model by themselves. But with the CKCC, so you partner with these value-based medicine companies. Who's in the driver's seat? Is the doctor in the driver's seat? Or is the startup in the driver's seat? Please take it. Go for it.
That's all Bij.
I think the thing is that first you have to evaluate what you can do in your local market, but then the other thing is that what is your risk aversion, and what is because the thing is you can obviously diffuse risk, as David mentioned earlier. You can diffuse risk when you have more patients, but also more providers. And so
Yeah, absolutely.
When I think about these different companies, I think that each one of these companies can offer something different, maybe for different practices around the country. I think that, personally, I love having the nephrology at the center, and I love having the nephrologist help decide some of what's happening and how the care is delivered.
Yeah.
But it's a little bit easier for a bigger practice, let's say, to do than maybe a 2-person or a 4-person practice, because you're running around, seeing patients, and it's hard for you to kind of set aside time to do that. So, but again, all these different models in the CKCC have different levels, where you can take a global model, you can take a professional model, and I believe that most of these companies are willing to offer different opportunities where they can cover the downside risk in terms of financial, but they can also offer some of these services. But I believe that the more you can aggregate your physicians, the nephrologists, this is really the impetus for nephrologists to work together, even in big metropolitan areas where typically and historically they've been kind of much more competitive.
So, I have another take on it. I think some nephrologists are going to be like, and I know some small nephrologists, the 1-2 physician practices, and they're just going to bury their heads in the sand and say, let it go, whatever. I'm not going to partner. But I think they danger themselves to think the fee-for-service model is going to be around 5 or 10 years from now. And so if they're not value-based in 5 or 10 years, then they're out of luck, right? Would you agree with that? Or do you think the fee-for-service model may still be around at that time? Go for it.
Qasim, adding to one thing to our small practice audience here, there's life outside disease models. If you want to practice value-based care, you can be part of, let's say, ChenMed. Most of my partner practices in local markets and nephrologists are 2-3 doctor practices. We like those practices, and you're partnering with a value-based company, and we set up a non-fee-for-service contracts or engagement with these nephrologists. We do global stuff and all that. So if you're a small practice nephrologist, life is it's not the end just because you didn't participate in ETC, KCC, or whatever. You can find MA plans, like MA care providers like ChenMed in your community, even the primary care doctors, and seek about partnership, and I think you will do well.
Because there's a lot of PCPs going at risk, and they want partners that are going to help them do better. Yeah, you're absolutely right. That's an excellent point. Got another question here. Let's see here. Question for the panel. Could you, Laurel, thank you for the question. Could you discuss the involvement of transplant nephrology teams in VBC currently and our desired future state? Anybody?
Well, I'll take. I mean, I believe, so I work in a transplant center, and our nephrologists and our surgeons are the ones that run the transplant center. We work with a tertiary care hospital in San Diego. I believe that this is critical to value-based care in nephrology. As nephrologists, many times patients look at us as preparers of dialysis. We actually have to be there to show them that we're giving them hope for a better life. We all know patients want transplants. And so the more integrated your transplant team is in terms of evaluation and education, even in their renal replacement therapy options, the better chance the patient has of being activated. We need patients to be activated. They have chronic illness. They have multiple comorbidities. They have lots of social determinants of health. And the key to success is having an activated patient that is participating in their care for them to help deliver value-based care. We all know we can only help patients that help themselves. It's very difficult otherwise. We can add all these different services, but I think the transplant portion of that is really critical to that. So if you don't have the opportunity to be able to run your own transplant, obviously most places can't, I would say developing that relationship with the local transplant center, getting the physicians, the transplant center coordinators, and the physicians on your cell phone so that you can make a phone call to make sure preemptive transplants can happen. Because with all the barriers, it takes a lot more push and to overcome those barriers to make sure those things happen.
And to your point, I think patient education is so crucial in the sense that they should know that when their GFR hits 20, that when they have 20% kidney function, they need to be referred to a transplant center, like automatically. But I think again, you're in a major metropolitan area. I'm in a major metropolitan area. You start to realize there's a lot of people in outlying rural communities that are nowhere near transplant centers. And so I think like that becomes a hurdle as well too, right?
For sure, but I think there's ways that transplant centers can have outreach. Sometimes we can talk. We've been talking about having a 1.5 day clinic of transplant evaluations a month.
Oh,
let's say for a transplant center to come out and maybe sublet some space out of their office. I think this is very important. I will also say that in San Diego, we've just built a new dialysis clinic that is basically all home focused. It's a transitional care center, but we're going to start transplant evaluations in the transitional care center. We're going to have our own evaluations going on there with education. We've already partnered with our local transplant center to do that. I think there's opportunities, but it does require that building of that relationship with that transplant center.
Cool. I'm going to take one last question. Oh, Sarah Lee, I know her. She's a really innovative girl. She's got a little startup of herself, a little med tech startup. How do you see value-based care models implementing, one, new device innovation in dialysis, and two, dialysis provider appetites for adopting new medical device dialysis systems? Go for it.
I'm going to take a stab and just say, design your stuff. If you're going to design a product and services, and if you're an entrepreneur who's designing it, design first for fee-for-service. Don't design for value-based care as your initial go product, your go-to strategy. Make yourself paid by the value-based care. That is still the predominantly paid service from who is going to pay for it, the commercials or Medicare, whoever.
Yeah.
Design your product and services accordingly. Down there, after that, adjust those services to see if it fits in the value-based care, which is basically in the capitated system. Does your product and service decrease total cost of care and in a way that predominantly that reduction will come from hospitalization. So whatever you're doing, does it tie into decreasing hospitalization? If that is achieved, then go market to the VBCs. That's my suggestion.
I actually agree with that. But yeah, excellent point. Because the current model is still fee for service, right? So I guess you have to get that CPT code or whatever it is, that billing component, to actually make your device profitable, right? And then once you prove that you save costs, you can go from there. Would you guys agree with that, or any other strategy, or would you design a device for value-based care right now?
I agree with what Mufaddal had suggests. I mean, it's going to be tough to just do it for value-based care. Again, this is all the excitement is great, and I think we're going in the right direction. I'm very hopeful for success of these value-based care models, but hard to know exactly, what device innovation, what it would cost, and how it would work, and really the application for each of the patients. So I would agree with the way to approach that.
Cool. Well, you know what? I think we've been on for 50 minutes, and that's enough time for 4 grown men to talk. So it's great having you guys. I am honored that you guys wanted to come on here, guys. It's been a great talk, and I'm hoping we helped out some people. We have some nephrologists. I got a lot of reach out from nephrologists just having questions about what's going on, and I just appreciate your time. So,
absolutely, thank you for having me.
Thank you for having us. Really appreciate it, Qasim.
Great, guys. So let's see here. Thank y'all for coming. I really appreciate it. It was a great talk. I really enjoyed it, and it was an honor to be with these guys. We're gonna check out now. Anyway, please leave more comments, and maybe we can get them answered. And also, again, you can go to Your Kidneys, Your Health to get CME credits and watch the videos that I have. Okay, y'all have a wonderful night. Take care.
Take care.
Thank you.
Thank you.